All right, guys, we've got a lot of information to cover, and you guys have an exam on this next week. So, I will say a lot of this we kind of went through yesterday in lab. So group 1, you kind of have an advantage over group 2. However, group 2, you have a little bit more of an advantage because by us going over this information today, it's going to make a lot more sense to you tomorrow. Okay? So, I'm like, come on now. Cardiovascular assessment. Now, we are going to be focusing more on the blood flow through the heart and the valves and everything else, okay? Come next semester, on top of that, you're going to learn about the electrical conductivity of the heart and how that moves blood through the heart and what muscles stimulate what, okay? So you really need to be very comfortable with the physiology and the anatomy of the heart, okay? So when you're going to be doing an assessment on a patient, oops, one too many. All right, there's a lot of things that we have to collect, okay? We have to do not only a auscultation of their heart and figure out if there's any extra tones that we're not anticipating, because there are supposed to be how many?
2.
There are 2, S1 and S2, but there can be S3 and S4, okay? We don't want to hear either one of those 2, preferably, okay? Then we can also hear regurgitation, which is the sloshing of blood within the heart. We typically want to hear that when we listen and auscultate the carotids, because that means that there's blood flowing through there, okay? That's a good thing, right? Unless you're a politician, that's just anticipatory, okay? Now, we only listen or auscultate the anterior portion of the chest because that's where the heart is, okay? Now, last week in respiratory, we talked about the anatomy being that up here, the lungs are called, what part of the lungs is this? Up here? No, this part of the lungs.
Bronchial.
Bronchiovascular.
The lungs. Not lung sounds. The lungs. Apex. I heard somebody back there say.
My bad.
Yes. Apex is up here. Down here is the bases. It's all about them bases. No trouble. Okay. I'm showing my age now. No, I'm just kidding. I'm young, really. Well, the heart's upside down. It's opposite that. Because the base is up here, okay, right behind the sternum, and then the apex is over here. Now, what do we feel over here that we can, what's something that we can palpate over here? Close. It's called PMI, point of maximum impulse, okay? It's not a pulse point, but you should be able to palpate a thump, 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 because the apex of the heart actually kind of goes up against the rib cage, okay? Now that's kind of, most students are like, well, wait a minute, the heart's not there because we put our hand over our heart like this for the Pledge of Allegiance, right? Well, that's because you could feel it over there, but technically your heart is right in the center of your chest. That's why we do compressions there and not up on the shoulder, okay? All right, auscultate heart sounds. Now, that website I gave you guys last week in lab, easyauscultation.com, they have heart sounds, okay? You, at semester 5 level, you only need to know what S1 and S2 are and how they correlate to the movement of blood through the heart. That's it for right now. Okay, don't worry about S3, diastolic murmurs, systolic murmurs, any of that stuff. All right? Okay. We're also going to be assessing the extremities, the peripheral pulses. Now, the main ones that we have to make sure that we are assessing: radial. Okay, we're going to listen to the neck, or auscultate in the neck vessels, which are carotids. Okay. Now, carotids are arteries. What are the names of the veins through the neck?
Jugular.
Jugular. Perfect. Okay. But we're also going to assess the radial pulse, and preferably both at the same time, without using your thumb. You went to Jersey Mike's and didn't bring me
She actually ate your half.
Oh, dang it, it was so good. The other two are the dorsalis pedis on the top of the foot and your post tips, which are where?
Where?
Your post tibial pulse point. Where is that?
Back of your knee.
Nope, that's
It's not
popliteal.
like the left side of your foot.
It's just behind the ankle bone on the medial aspect, so on the inner ankle. Okay? And we'll go through these again tomorrow, group 2 in lab, so don't worry. Okay? We are also going to make sure that we are listening with as clear ability as possible. For the carotids, you do need to make sure that you're utilizing what portion of the stethoscope? Group 1, yeah.
Not the bell.
Diaphragm.
You use the bell.
You use
Oh.
the bell for the carotids, because it's a lower pitch sound that you're listening for. Okay? You want to use the diaphragm when you're auscultating the vowels. Okay? So remember that. Carotids, you need to use the bell. Okay? But also too, about 49% of the population has a propensity to have chest hair. Because ladies, you make up 51%. And if y'all got together, us guys are in trouble. But, because we're outnumbered, guys, we are outnumbered. But we typically have chest hair or body hair. And if you're trying to listen to somebody's chest and you're listening over hair, it can cause a staticky sound. So what were the two ways that you can kind of dampen that a little bit? Shave is one, or wet it. So that way it's less dry sounding and frictioning. It's more smoothed down, okay? And you want to make sure you are listening and putting your stethoscope up against the skin. Try not, yesterday in class I had the students auscultate over their clothing and then underneath and right up against the skin so that they could hear how different and how muffled the sound is. So you guys will be doing the same thing tomorrow. All right? There it is. All right. So we know that the heart is a muscle about the size of your hand or your closed fist. Okay, it's not very big. It delivers oxygenated blood through the rest of the body and brings the deoxygenated blood through the lungs so that it can get oxygen and then go back around the same way. Okay. Also helps with removal of metabolic wastes. So those would be what? CO2 is a waste. But what other type of metabolic waste can we get rid of through the blood? Think about the other filters within your body. Uric acid, toxins, yeah. That's kind of a blanket term. But what is the liver filter? Out. Creatinine's kidney. You might want to know those things, guys.
The liver will filter out LDL and HDL.
It has something to do with cholesterol, yep. It also filters out a lot of toxins. There are two main filters in the body, okay, and this will come up again to bite you next semester in pharmacology that you need to be very familiar with. One is the liver, the other is your kidneys, okay, because either one of those organs, or in some medications both, will metabolize out the drug and cause the effects and tell you how long it's going to stay in your patient's system. Okay. We talked about the top part of the heart is the base, the bottom is the apex. The area that is the strongest force of blood flow is the point of maximum impulse, which is right over here. Right around your fifth intercostal space, mid-clavicular line, which we'll get to that in a minute for the group 2 peeps. Come on. All right, whoop. Now all of a sudden it wants to play catch up. How many oscillatory points are there for the heart?
5.
There are 5. You need to know all 5 and what you're listening to and where, okay? So first off, this whole area So from the top, that suprasternal arch up here down to basically the xiphoid process is called the precordium, okay? You need to look at your patient's chest to see if you can see what's called heaving, where this part of the chest is moving, okay? You also need to palpate it to see if there's any thrill, okay? Now you feel a thrill and you hear a bruit, and that term's gonna come back in a little bit, okay? Some parts of the body you want a bruit, others you don't want a bruit at all, okay? But your 5 auscultation points is the aortic, the pulmonic, Erb's point, tricuspid, and then over here is the mitral valve. So we used to say, you know, just remember ape to man, because you have A, P, E, T for 2, and then M for man. Some people didn't like that because that deals, you know, with Darwinism. Some people don't believe that we came from apes, whatever, okay? So now, and the newer mnemonic is All People Enjoy Time magazine. Like, personally, I like Weekly World News, but
I'm offended.
you can be offended. National Enquirer, okay? All right, and as far as structures within the heart, you definitely need to know the difference between a pericardium, myocardium, and endocardium, all right? So breaking this down, pericardium, peri, think of like a perimeter. That's the surrounding area outside the heart. Cardium meaning heart. Myocardium, that's the muscular part that actually does the squeezing. So that's all this pink stuff that's on here, okay? Then we have the endocardium. That's the inner layer, the endothelial layer of within the heart itself, okay? You need to know that there are 2 atria and 2 ventricles, okay? And there's another slide that we'll get to in a minute about the blood flow through that. You do need to be familiar with that as well, okay? Now this is, I love the heart. It is so amazing how complex it is, but yet how simple it works. So we have the 4 chambers, which are the 2 atria and the 2 ventricles down here. And then between those, we have the valves that keep the blood going in one direction. We don't want blood going back and forth, okay? We want it to stay going in one direction. So those valves help prevent regurgitation, or the movement backwards and forwards. So when somebody has like a mitral valve regurgitation, that means that this valve is not closing all the way, and as the heart goes to squeeze blood through, when it relaxes, it pulls blood back. So it's not an efficient way for blood to be moving through, okay? There are 2 AV valves. You have your tricuspid, which is coming from your atria into the ventricle on the right side. And then you have your mitral valve, which is going from your left pulmonary veins your left atrium into the left ventricle. And then after they go from the ventricles, now we have our semilunar valves up here. One is our pulmonic valve, and the other is your aortic valve. All right. Now we know obviously that they separate that. Now, why are those so important to know when it comes to auscultating the heart?
Because does it have something to do with like the sound, like love and dove?
Correct.
And love is tricuspid in the aortic? Or
We'll get there.
Okay, sorry.
Okay. But in the cardiac cycle, okay, we already know from taking a blood pressure, what are the 2 numbers mean? What's the top number mean? Systolic. And then the bottom number is diastolic. Those correlate to the phases of the cardiac cycle. Your heart will become systolic when it's squeezing, when it's in the active part of it, okay? That's why that top number can fluctuate, because it's going to change with each pump of the heart, okay? But then that bottom pressure, that diastolic number, that's when the heart is in its state of relaxation or diastole. Okay? And that amount of pressure is constant. Okay? It will change a little bit, but it doesn't fluctuate anywhere as much as the systolic pressure will. All right? It was right here. Oh. Shauna was stealing it. Let's see how it is. There we go. All right. Just talked about that. So when it comes to cardiac failure, you guys have heard that term? Congestive heart failure or something like that. The main function of the heart is to what? Pump. Okay? If it's not doing it effectively to where there's no complications throughout the rest of the system, okay, because the blood goes through everything, right? When it is not able to pump effectively anymore, that person has heart failure. It's no longer effectively pumping the blood through, okay, and can cause complications. Now, I have a couple slides at the end, but the main thing I want you to remember as far as differentiating between the two is that left-sided heart failure will manifest in the lungs. So left lungs, those symptoms with that, okay? With right-sided heart failure, it's going to manifest everywhere else, typically in the lower extremities, okay? When we get to the blood flow through the heart in a couple of slides, actually I think it's the next one, it is, we'll get into that a little bit more, okay? So here we have a lovely example of blood flow through the heart, okay? So starting from the right atrium, we go through the tricuspid valve into the right ventricle. From the right ventricle, we go through the pulmonic valve, and then go to where? The lungs, okay? Now this is blue, but this is a pulmonary artery. Why is it an artery if it's blue? Arteries push blood away from the heart. Veins bring blood to it. This is like really the only one that's flipped, okay? We have this one, and then over here we have the pulmonary veins, but they're oxygenated because it's pulling blood to the heart, okay? So now we've gone to the lungs, we've been oxygenated, we're coming back through the pulmonary veins, into the left atrium, through the mitral valve, into the left ventricle, and then we go through the aortic valve and go where? Well, there's one place that it goes first, to the brain, okay? Then it goes off to the rest of the body, okay? So you do need to be familiar with that. As far as blood flow through the cardiac valves, just remember to tissue paper my assets. Make sure that those assets if you want to tissue paper that's fine. Okay? But yes, tissue paper my assets. We go from the tricuspid, then through the pulmonic, then we go out to the lungs, come back from the lungs, go through the mitral, then through the aortic. Tissue paper my assets. Yes, sir.
So superior vena cava and inferior vena cava, those are not the same time, different time.
Say that again?
Like you were talking about the blood flow, so it's superior vena cava first.
Well, the vena cava itself is all one structure that empties into the right atrium. It's just whether it's above the heart or below.
Right.
Okay? So that's just another version of that same slide. All right, so here we have it coming in through this way. This is supposed to be actually pumping, but maybe I didn't set it up the right way. So the things that you need to know as far as tools that you need to have when you assess your patient's cardiac, of course you're going to need your stethoscope. Why are we going to need a watch? heart rate. Okay, and believe it or not, even though you wouldn't think it's related, your respiratory rate. Okay, because if the lungs aren't oxygenating the body very well, what's going to happen with the heart rate?
It's going to increase.
The heart rate's going to go up. Okay. You're also going to need your pen light. You're going to need that because you're going to be assessing for JVD. Now, what's JVD?
Jugular vein distension.
Jugular vein distension. Okay, that's another indicator of right-sided heart failure. Okay. Then we have this lovely tool. Do you guys remember what this is called?
Doppler.
Your Doppler. Okay, so if you can't feel a pulse, use that. Okay. Now, this isn't going to be something that you're going to be tested on, but I'm putting it out there for you guys to know. Not this semester, but next semester, you guys might be going to like a telemetry unit, and you might have patients who wear a telemetry pack, which measures the electrical conductivity through the heart. That gets us that nice little, green thing on the screen. Okay. But make sure that you're placing the right color leads in the right place. And so the main ones are, this is just for 3 leads. Most places have 5, but just know that the white lead goes on the right part of the chest, smoke over fire, so black on the left, and then fire red just below that. Okay? The other one would be right over here, would be a green. And then brown is the center of things, and it would go right along, not exactly over the sternum, but just to the right of it. Okay. Lots and lots of subjective data. Do you have any problems with your heart? Do you have any chest pain? Big thing is family. Okay. Any family history of heart problems? Okay, when you guys get to kids, you're gonna, learn about what's called the tetralogy of Fallot, which is when the blood flows all wonky, okay, through it with a kid, or they might have an open ovule, which is a hole in their heart, and allowing for blood to go back and forth between the 2 atria, which is not supposed to. That's supposed to close when we're born. Doesn't always happen though, okay? Peripheral vascular disease, we want to know if they have any numbness or circulation problems in their feet, not just diabetics, okay? People with heart issues as well. Do they have any pain in their arms, their neck, their jaw, as it can radiate up this side of the neck? Now me, personally, when I had my heart attack, I was having pain right underneath my heart, here more so. It felt like I had been having indigestion all day and nothing worked for it. I tried Maalox, I tried Tums, I tried Rolaids, all those fun things. Could never get anything to take care of it. And then when I laid down and I couldn't breathe, I was like, let's check this out. And I got my blood pressure cuff out and checked my blood pressure. It was way through the roof. So don't always just automatically think, oh, well, they're not having, chest pain. What other symptoms are they having, okay? And just as a side note too, February is cardiac health awareness month. And you guys know why the symbol for that is a red dress? Women have a tendency to not follow the stereotype of having chest pain. Where do they typically develop pain when they're having a heart attack? No,
Jaw.
their upper back, just below, just in between their shoulder blades. And they just think, well, maybe I overworked it today, and then they just keep going on about their day. They don't realize that they're having a heart attack until they pass out or that the pain gets worse. So, yeah. All right, so of course we're gonna do inspection, palpation, and auscultation. Make sure that you're doing your hand hygiene. Make sure that the expectation is to clean your stethoscope after every patient encounter, okay? So you just need to clean it off with alcohol wipe. I usually grab like a handful and put them in my pocket so I have them just there. Make sure you're maintaining your patient's modesty. Don't just go in there and flip their gown down, okay? Some guys will be like, hey, or whatever they do for that I don't have the muscles, so I can't do that. But trust me, you do that to a lady and they might smack you, all right? And explain, of course, the purpose of the exam and what you're doing. So what do you think you need to say? After you've introduced yourself, all that fun stuff. I'm here to listen to your heart, okay? Make sure that, you will have to palpate, like I said, the chest area for, what were the two things I gave you? No, here, the precordium.
Brewery and thrill.
Thrill and was it a brewery?
Yeah, you listen to brewery, that's right.
Yeah. Heave. Heave or a thrill for the precordium, okay? We're gonna look for findings of cardiovascular problems. What would you think those would be? Hmm?
Like when it shakes in the middle, right?
When it shakes in the middle, that's the thrill.
Okay.
Yeah, okay. But what are some other findings of CV problems? They might have cyanosis of the lips. They might be having, they might feel like they're breathing okay, but their heart's not pumping well enough. Okay, we might have edema. Tomorrow, group 2, you're gonna get a nice handout, and I think I have it in the. Actually, yeah, it's the next one. You're gonna get a copy of this that has a lot of cardiac clues. Some of them you're probably gonna be like, well, how does that have to do with breathing or with the heart? Heart and lungs go hand in hand, okay? Because if you don't have enough oxygen, what's going to happen to the heart? It'll eventually stop, okay? So, but if you don't have a heart rate, you call the code and start jumping, okay? But yeah, now, do you have to know all of these for the test?
Yes.
No. I would definitely suggest that you are familiar with how the heart can affect other areas other than just the cardiovascular system though, okay? All right, we're gonna note jugular veins and look for any distension. We have to make sure that the head of the bed is anywhere between 30 to 45 degrees. 45 degrees is best when you are assessing for JVD, okay? Because you want some pressure so that makes it a little bit more prominent so that you can see that bulging right here. Now, when I turn my neck over to the side, what pops up right here?
Jugular vein.
No, this is a ligament,
Oh, sorry.
okay? So this is not JVD. It would be right alongside this and you would see a pulse, okay? Do veins pulse or do arteries pulse? Or should they pulse, I should say?
Artery should pulse.
Arteries should pulse, not a vein, okay? So if it's further in, like closer to where the thyroid is, it's more likely an artery, okay? But if it's further out and alongside that ligament right there, that's a jugular, okay? Now this is what it kind of looks like right here. So you have that ligament kind of hiding behind here, but then you have this pulsation going on. All right, we can feel for the pulse. Here, we of course want to check for, what are we checking when we assess pulse? Other than heart rate.
Symmetry?
Symmetry, we want to make sure we're feeling the same on both sides. Do we feel the carotids at the same time? No. Unless you don't like your patient.
For strength, as far as like it'd be like a +2 is technically what we're looking for.
Correct. Why wouldn't we want a bounding pulse? What would that mean if we found a bounding pulse? Very strong pulse.
There's like blood force or
Too much pressure.
There's too much volume. So they're either severely overhydrated or they're having heart failure issues of some kind where it's backed up to that point to where it's affecting the other side of the heart, okay? You want to take it out and light pressure. If you do hard pressure, you're creating a diaphragm. You just want to make sure that it's sealed all the way around, on the skin, and just enough to where you can hear that nice little whoosh, whoosh, whoosh. You might hear breathing, because what area is right in this area? You got your trachea right here, so you might hear tracheal breathing. But how would you differentiate between breathing and the heart rate? Especially if they sound the same.
Hold their breath for a second. Hold their breath for a little bit.
You could do that, but a heart rate's gonna be more frequent sounding. It's gonna be, you know, whereas breathing, okay, it's gonna be a little bit slower. So, all right. Inspection, we're gonna look at the chest to see if there's any abnormal movements, okay? Gonna look to see if there's any visual palpation, or excuse me, visual pulsations, that's the word I was looking for PMI. All right, again, that's leading back to that bounding pulse. We should not have that, okay? We should be able to palpate it, but not see it, okay? Now, there's a video that I was going to play for you guys regarding the difference between a bruit and a thrill, but I do believe you guys have access to that in your PowerPoint. Is that right?
Yes. Copy of
Everyone's
it.
like, I'm on Netflix right now, I have no idea.
Yes, it's there.
Some people even went like this. Are you really on Netflix right now? Yeah, better connection than I do. All right. So yeah, I would definitely highlight this section right here. You feel a thrill and hear a bruit. Okay. Now, we want to make sure the best possible place for our patient to be as far as position is sitting and kind of leaning forward. It's just going to bring the heart that much closer to the front of the chest to make it easier to auscultate the different sounds. How often is that going to be possible necessarily in the hospital? Not always. Okay, in the ICU, if they're sitting up, they shouldn't be in the ICU. Okay, so typically they're laying supine, or when we're doing the lungs, we'll have them turn up on their side or whatnot. But sitting in a sitting position and leaning forward is the best position for them, because then it also has the heart in that position, allows for you an easier time of hearing any extra sounds, that S3, S4. You don't need to worry about those for now, but by the end of the program, you should know what those are and how to auscultate those, okay? We already talked about ape to man. Now, with your heart, we've talked about a regular or irregular rhythm, right? I know we've talked about the rate with being bradycardic, or what's the other one? Tachycardic, okay? But when I'm talking about rhythm, okay, your heart should be pumping at a pretty distinct type of order and frequency, right? So that would be regular, but it can sound like a freaking pinball machine going off in there, because okay, which obviously, do you think that the heart is functioning adequately when that's the rhythm that it's doing anything in? No, because we have to have enough time from when it's squeezing and then relaxing to allow for refilling, okay? Now, contrary to popular belief, the ventricles don't squeeze at the same time. They alternate back and forth, like this, okay? Because they don't have a whole lot of room, okay? This is all enclosed. What's on either side of the heart?
Pericardium.
Think bigger.
The lungs.
The lungs. There's not a lot of room right in here, okay? So it uses the space very efficiently. So while this side is relaxing, this side is squeezing back and forth. Just like, if you guys ever seen a cow get milked?
Yes.
Do they take all of them and go like this? No, they go like this, okay? It's the same thing with the heart. They've got to wait for that teat, or that portion of the teat, to refill with milk, so that way they can squeeze it out. It's the same kind of principle here, okay? Now, the two phases that you need to be familiar with are lub and dub. S1 and S2. Okay? S1 or lub is when the tricuspid and the mitral valves are closing. Okay? So the right ventricle has filled and the left ventricle has emptied. And they're not allowing for blood to come back this way. Okay? Or continue going this way. Then we have dub, which is with the aortic and pulmonic valves are closing. Okay? So now this is opening up and this is squeezing on this side.
Well, but isn't there a standard amount of backflow with every single heart? It's just when it gets to a certain point.
Very
it becomes an
minimal.
issue.
Very minimal. And like with regurgitation, the valves aren't closing all the way.
Yeah.
So that can cause more turbulence. And with the turbulence, you can get blood that pools on either side of the valve here. And then
Okay.
it creates, because if blood's not moving, it
Yeah.
clots. And then all it takes is somebody to, get into a car accident or to exert themselves too much, and then that clot goes boom, right up to the brain.
Ah.
It causes a stroke. Okay. Now we talked about this. If you are into landmarks, okay. Now, a lot of times we want to default to what we can see as far as a landmark is concerned. But what's the problem with that on the human body? With skin.
It's usually like uniform.
Skin stretches over time. Okay. Ladies, the girls kind of go further south. Okay. Guys, same thing happens, just towards the knees. But it's true. Skin sags. You get rolls, you get skin stretching, all that fun stuff. So we tend to use the skeletal system for landmarks, because how often does the skeleton move around or change its position? Not really. Okay. Even when we have a patient that's intubated, we have to mark the depth of the tube that's going into their lungs. We don't use the